Hello friends, this is Nishant. I am here with the next video on ECG, and in this video I want to talk about ST segment and QT intervals. Now let's draw a normal beat of an ECG. This is a P wave, this is a QRS complex, and this is a T wave. So P, Q, R, S and T. So ST segment, as the name implies, is from the end of QRS complex to the beginning of T wave. So this is ST segment. And QT interval is, as the name implies, from the beginning of Q wave to the end of T wave. So this is QT interval. Now these both of these areas are very vital, as you will notice in the subsequent part of the presentation. So without any delay, let's get started. Now the ECGs and diagrams that are used in my video were borrowed with permission from following two websites: ecg.utah.edu and ecglibrary.com. These two are very good websites if you want to practice additional ECGs or learn about them in detail. Let's talk about one of the very important areas of ECG called ST segment. Now, ST segment is measured from the end of QRS complex to the beginning of T wave. Now, as we all know, QRS complex denotes ventricular depolarization, and T wave, about which we are yet to talk, denotes ventricular repolarization. This is the area between these two, that is end of QRS complex to the beginning of T wave, and it should normally be isoelectric. What is the meaning of isoelectric? Isoelectric means it should be flat. Now, how to say that if it is isoelectric or depressed or elevated? Compare it with TP segment. So if I were to draw two successive beats of ECG, in this ECG we can easily say that this is a ST segment and this is a ST segment. To compare if it is elevated or not, I want you to compare it with this segment, that is TP segment. TP segment is always isoelectric. So if ST segment is either shifted up or down, that is a change and it should be taken very seriously, as it can potentially be life-threatening. So what are some causes of ST segment elevation? First and foremost, and perhaps the most important, is ST segment elevation myocardial infarction. Then there is something called as vasospastic angina or Prince metal angina. Then ST segment elevation can also be seen in ventricular aneurysm and acute pulmonary embolism. But according to me, the most important thing to remember is ST segment elevation myocardial infarction. Then what is the criteria? I mean, how much ST segment elevation should be there to call it a significant ST segment elevation? So I want you guys to remember that ST segment elevation of more than 1 millimeter in limb leads and more than 2 millimeters in chest leads is considered as significant ST segment elevation. Then there is something called as ST segment depression. ST segment depression is seen in NSTEMI, that is non-ST segment elevation myocardial infarction, and subendocardial ischemia and angina. The mechanisms of ST segment elevation and ST segment depression I have explained in detail in my videos on myocardial ischemia. As it is not possible to include everything in this lecture due to time constraints, let's interpret this ECG. I am going to take a 1-second pause. Alright, let's have a look at ST segments. So if I were to see a ST segment of lead 3, this is the ST segment, and to compare, I would like to compare it with the TP segment. This is the TP segment. You can pretty much say that TP segment and ST segment are pretty much at the same height. So with respect to ST segment, this is a normal ECG. Let's interpret one more ECG. I will take a 1-second pause. Alright, so let's look at ST segments. So if this is the TP segment of lead 2 and this is the ST segment, you can comfortably say that the ST segment looks elevated. Then again in lead 3 you can say that ST segment looks elevated, and in lead AVF the ST segment is elevated. So can you guys remind me which wall do these three leads look at? 2, 3 and AVF. Again, that's a inferior wall. So this is an ECG showing inferior wall STEMI. Let's move on to the next ECG. So I'll take 1 second pause for you guys to interpret this ECG. Alright, let's have a look at ST segments of various leads. I would like to begin by lead V1. In lead V1 you can see that this is a TP segment which looks pretty much horizontal. Then if you see the ST segment, it looks depressed. Again in lead V2 ST segment looks depressed if this is TP segment. So, and let's look at inferior leads. Lead 2, 3 and AVF are inferior leads. The ST segment here as compared to the TP segment is seen to be elevated. Yes, so there is ST segment elevation in 2, 3 and AVF, and then there is ST segment, this is ST segment elevation, and there is ST segment depression in lead V1 and V2. So this is an ECG showing inferior wall STEMI and reciprocal changes in the anterior leads, that is V1 and V2. I'm going to talk about reciprocal changes in detail in my next video, my video on myocardial ischemia. Let's have a look at one more ECG. Have a look at ST segments in different leads. I'm going to take a 1 second pause. Alright, so if this was the TP segment and this was the ST segment, you can comfortably say that ST segments are elevated in lead V1 through V4. So V1 to V4 is ST elevation, and you can say that ST segments are depressed in lead 2, 3 and AVF. So ST depression in 2, 3 and AVF, which is quite opposite of the previous ECG we saw, isn't it? So this is an anterior MI, anteroseptal MI showing ST segment elevation in V1 through V4 and ST segment depression, that is a reciprocal change in lead 2, 3 and AVF. Again, I talk about reciprocal changes in detail in my video on myocardial ischemia. Let's talk about QT interval and QTC. First of all, QT interval is measured from the beginning of QRS complex to the end of T wave. This is QT interval. Now it is measured only in limb leads. So if you are looking for QT interval prolongation, chest leads might not be the best place to see. Then I also want to introduce a concept of QTC, which is QT corrected for heart rate. That is calculated by Bazet's formula and is given as follows. QTC is equal to QT interval in the given ECG divided by square root of RR interval. So that is QT interval divided by square root of RR interval in seconds. You have to keep the RR interval in seconds, and QT interval you can keep in seconds or milliseconds. So what are the normal upper limits of QTC? If QTC is prolonged, then these two values, it is considered as a prolonged QT. So in males it is less than 0.45 seconds and in females it is less than 0.46 seconds. These values are given differently in different books. For the purpose of this video, I have referred Goldman Cecil Internal Medicine 24th edition. In general, if you want to remember it roughly, you can remember that QT interval, which is more than 2 large boxes, is considered as alarming and warrants investigation into causes of prolonged QT interval. Let's have a look at few ECGs. Let us remind ourselves of the last line of previous slide. That is, QT interval should not be lengthier than 2 large boxes. So let's start marking a few QT intervals. Say this is the beginning of QRS complex and this is the end of T wave. You can comfortably say that it is definitely not more than 2 large boxes. So it is less than 2 large boxes, which tells me that this is most likely a normal QT interval. I'll take a 1-second pause for you guys to interpret this ECG. Alright, number 1, let's remind ourselves that QT interval should always be measured in the limb leads and not the chest leads. Then let's mark some QT intervals. In AVR, you can see the QRS complex begins here and T wave ends here. So this is 3 large boxes or 0.6 seconds. So let's mark one more. If this is a beginning of QRS complex and this is the end of T wave, then this is QT interval, which is again approximately 3 large boxes. So QT interval is prolonged here. What are some important causes of prolonged QT? Number 1 is electrolyte disturbances like hypocalcemia, hypokalemia, and hypomagnesemia. Then there comes a group of disorder called as congenital long QT syndrome. There are 3 types of congenital long QT syndrome: LQTS 1 to 3. So these are the causes of prolonged QT that I want you guys to remember: hypocalcemia, hypokalemia, hypomagnesemia, and congenital long QT syndrome. Let's have a look at one more ECG. Let's start marking QT intervals. So let's mark this as from here to here. You can clearly see that it is more than or equal to 3 large boxes. And in some other leads, if you want to see, it's here to here. This again is approximately 3 large boxes, which tells us that this is a prolonged QT. So this is very important. This becomes very important as there are some meds that cause QT prolongation that are contraindicated in patients having long QT syndrome. Can you guys remind me of a few such medications? There is an exhaustive list, but to remember a few antibiotics like erythromycin and antiemetics like ondansetron prolong QT. So for QT interval prolongation, I want you guys to remember it under 3 categories. Number 1 is congenital, number 2 is electrolyte, and number 3 is drugs. This is very important in clinical setting as combination of any two of them at once, at simultaneously combination of two of them can lead to arrhythmias called as torsades. Those are pretty dangerous arrhythmias and hard to treat and are potentially life-threatening. So QT interval, looking at QTC before giving any QT prolonging drug is very useful and potentially can save lives. Thank you so much guys for watching my video. If you like my video, please subscribe to my channel. I will be posting series of videos on ECGs and other topics in upcoming weeks. If you have any questions, concerns or doubt, please feel free to reach me at love.intmed@gmail.com. I want to thank Dr. Frank Yanovich of ecg.utah.edu and Dr. Dean Jenkins of ecglibrary.com for allowing me to use their ECGs. Then I want to thank two of my best friends, Dr. Pranav Patil and Dr. Aditya Tolat, for their valuable inputs in designing and modifying this presentation. Here comes the mandatory slide. I like to conclude all my presentations by the next slide by remembering the motivation for me to come in the field of medicine. My uncle, late Dr. Sanjay Tiwari. I used to call him Dr. Chacha. I just want to give him one message that whatever I am is because of him and he is being missed every single day. Thank you so much guys and I wish you good luck.